Welcome to the CME Essentials audiocast, covering current topics in clinical medicine. The show helps clinicians stay up to date on the current standards of care and catch up with the latest clinical developments and trends. Each episode features a lively discussion between the physician host and a noted clinical expert. They dig into the issues practitioners face every day and provide insight on improving patient care.
Hello and welcome to another installment of Oakstone's CME Essentials in Hospital Medicine. I'm your host, Dr. Monique Lucarelli. I'm a board-certified internist with experience teaching residents and hospital medicine fellows. I've been a part of Oakstone's Practical Reviews in Hospital Medicine team for nearly 10 years. This is now my third time hosting CME Essentials. Today, I'm joined by Dr. Adam Hunzeker as we discuss the management of comorbid depression and anxiety in hospitalized patients. Dr. Hunzeker is a board-certified psychiatrist who practices at First Health Moore Regional Hospital in Pinehurst, North Carolina. He has been practicing since 2006, spending his first 15 years in practice with the U.S. Department of Defense. Dr. Hunzeker, welcome to our program.
Thank you, and good afternoon. I appreciate being here today. Thanks.
Our discussion is presented in two parts. In part one, we'll start with why it is important to address anxiety and depression in hospitalized individuals. We'll introduce a case and talk about potential interventions. In part two, we'll dive into screening tools, introduce another case, talk in depth about hospital treatment options, and finish discussing strategies to improve care transitions. As usual, we will end each episode with our key takeaways. I'd like to begin with a few words about why this is such a critical area for hospitalists. As many as 6 in 10 individuals with chronic medical conditions also experience depression, and nearly 8 in 10 with depressive symptoms have a comorbid physical condition. Moreover, depressive disorders are linked with higher healthcare utilization and costs. A meta-analysis published in 2018 showed that hospitalized patients with depression spend nearly 4.5 more days in the hospital on average than hospitalized individuals without depression, and they are more likely to be readmitted. This means that we hospitalists are not only treating these patients, but treating them for longer, and the odds are higher that we will see them again if they are readmitted. Unfortunately, many of these patients are hiding in plain sight. It's well established that depression often remains undetected in hospitalized individuals, exacerbating both physical and other psychiatric symptoms. Hospitalists are working at what many agree is a critical detection point for intervention. Yet screening is controversial and not universally recommended. And for several reasons, hospitalists might not feel comfortable addressing patient mood. So let's sort through the challenges and opportunities and discuss what we can do as inpatient clinicians to improve outcomes in those we're treating. Dr. Hunzeker, I've just laid the groundwork for our discussion. How should we think about anxiety and depression, and why it might be important for us to address anxiety and depression in hospitalized individuals?
Yes, absolutely. We actually worked together for several years, and so I know that you believe in all these things as well. And one of the things, as we have begun in medicine, is important to take care of the entire person, right? Is biological, the psychological, the social, the every part. As we have become specialized, and it's much harder to encompass the entire patient. And so many aspects of a person's illness, which is not just the biologic piece, we don't get the chance to attend to. And I know we're going to talk about this a little bit later, but talking about modal treatment teams, or how we come together to treat the whole patient. And that's why it's so important, especially in this crucial group of patients that we have on inpatient. Like you said before, 30% of these people may be having depression or severe anxiety at this time that are going to create obstacles to their getting better in their treatment. So it's important that we all get on the same page in how we approach it.
I'd like to talk a little bit more about the fact that hospital depression and anxiety is underdiagnosed. It seems to me there's a kind of tension here between two opposing forces. On the one hand, if patients who may need important interventions are going untreated, this may lead to longer stays in the hospital, and they may have a higher risk of being readmitted. The data suggests this can be prevented if we intervene. On the other hand, screening is controversial, and hospitalists may not wish to intervene for a number of very valid reasons. Can you give us some guidance on where that sweet spot is? In other words, when do we intervene?
Unfortunately, you're an internist asking a psychiatrist, what he thinks about screening for depression and anxiety. I believe screening should occur for everyone. And I believe the model is actually moving towards that. Many hospitals now screen everybody coming to the emergency department for at least suicidal ideations and, depression as they're coming through the emergency department. Many other specialties are doing the same, especially like dialysis. They're doing depression screenings and suicidal screenings now. I find it to be very vital because it's one of those things, it's like a Pandora's box. When you open it up, there's going to be more to it, especially when 30%, that is a huge number, 30% of the people that are coming through your services are suffering from severe, depression or anxiety that would likely have better outcomes. Now, the question is what the resources you have and whether you can get into them. But I think the sweet spot is at least superficial screening, and if positive, at least a brief discussion about how it's going to be addressed or a plan of addressing, or at least referrals or getting into it. And I think we're going to talk about specific screeners in a little bit, but I would say that some of these things may add 5 or 10 minutes. Now, the question is how the system is going to approach if they're positive. That I think that's what the reservation is, especially, we are in a crisis of not having enough mental health resources. What do we do when they screen positive? How do we address their issues while you guys are fully busy treating all the medical problems people are there for?
Okay, so it sounds like this may be a little bit of a fluid area as far as screening. We may eventually see some different guidance coming down the pike from the researchers. This feels like a good time to present our first case and discuss how to manage an individual who might be showing signs of depression and anxiety. Tina is a 70-year-old woman rehospitalized 1 month after having a stroke. She lives alone and has recently been discharged from the skilled nursing facility. Her rehab is now outpatient. Her therapist noted a recent backsliding in her progress with mobility. She suffered a recent fall, and the family doesn't think she's taking her medications correctly. She reports needing help from family since she doesn't drive. She also says she doesn't see a point in living and that her family would be better off without her. She inquires about the new state law legalizing physician-assisted suicide. While there's no indication in her record that she made these observations during her initial hospital stay, she did say during that first visit that she was tired of being sick and that she, quote, can't do this anymore, unquote. Before we dive into how to manage Tina, I want to point out that Tina has been readmitted to the hospital and is now expressing suicidal ideation. During her first visit, she very generally expressed a weariness of dealing with her condition. Dr. Hunzeker, is there anything hospitalists could have picked up on and acted upon during Tina's first stay that might have lowered the odds of her being readmitted? And if so, what would you have recommended?
So one of the things that I think is super important in a case like this, especially as psychiatrists coming into consult liaison role, talking about a case like this that's rather complicated, is talking about the inherent qualities of psychiatric diagnoses. If you look at our manual, right, the DSM, what it actually says in the first several pages is a balance between validity versus reliability. So we talk about the word depression. The issue with the word depression is it's both a symptom and it can be a diagnosis. Major depression, I would believe the vast majority, if not all people going through a stroke or suffering some severe medical illness will be feeling depressed. Now, the question is when we call it depression. And so the important part as we approach a treatment like this is the understanding that in psychiatric diagnosis, we have sacrifices validity for reliability, which means we can make the diagnosis over and over again to study it. And so it's different than a lot of algorithmic medicine. It's more empiric. We are a treatment of palliative versus curative. And so the important part is in typical medicine, you set up a system that you're studying, you study the physiology, you determine the pathophysiology, and then you identify a disease state and intervene, curative or palliative. For psychiatry, We don't fully understand the system, we don't fully understand the physiology, and we don't fully understand the pathophysiology behind those illnesses. So it's important to see how our role is for this individual. I think especially if you're doing for a patient like this who's going through, I would advocate as a psychiatrist, any patients that are going through chronic medical illnesses, that they have screeners, because we've seen that outcomes are better and they can be referred to psychiatric assets. So especially someone post-stroke, the rate of depression is sky high. And interventions, even things like antidepressants, are incredibly cheap with good return on investments. So anybody who does an internal, like who takes care of patients like this, initial screeners are very important. And then getting the assets in. In our hospital here, referral to psychiatry is very common. And so that way, at least we can assess and see where the patient's at. And that's the important part about not getting too stuck on the diagnosis of major depressive disorder or generalized anxiety disorder, between understanding, is this patient having severe anxiety that's creating obstacles to their getting better or to getting the care that they need. And so I think that early is better. So even before the stroke, maybe if they got in that she was suffering and she was stagnating in her progression, with some sort of either PHQ-9 or GAD-7 screening exam. And also something that we don't like to talk about, but another anxiety disorder that happens very commonly, which is post-traumatic stress disorder or acute stress disorder, because people are going, like, a post-traumatic stress disorder from ICU is very common from after major medical illness or near life-ending illnesses. And those are also things that need to be treated as well.
So it sounds like we should be less hung up on the details of diagnosis as opposed to just focusing on how to help the patient and what they're feeling. As you mentioned, Tina had a stroke. I'm interested in knowing if there's a specific association between stroke or other specific clinical conditions and anxiety and depression.
Yes, without a doubt, depression and anxiety are very highly associated with particularly different kinds of strokes. A lot of them affect the emotional centers of the brain, which can be very commonly associated with depression and anxiety. Ones that affect, like Broca's area or speech centers, can also cause it, and anything that causes frontal lobe strokes can also cause a lot of issues with personality changes and emotional changes, which can be associated with depression and anxiety as well. And I said it as well, anyone who goes through a near life-ending or major life-changing thing suffers from post-traumatic stress disorder, which can affect their outcome, long-term outcome.
So as for managing Tita going forward, what diagnostic criteria would you want to document? And as a generalist, how would you screen her for depression or anxiety, or is that even necessary?
Well, remembering that between 20 to 40% of people with strokes will suffer from a major depressive disorder, that it's a very high likelihood. So there's a large pretest probability. The typical screeners that we use, PHQ-9, it's an inventory. There's also HAM-D and other sorts of screeners that exist. The typical screeners that we use is assessing, how they're doing. So some part of it's what they report. Sometimes people don't report it, but seeing if they're sleeping, seeing if they look disinterested in their care, if they're talking about how bad they are. You had described some passive suicidal ideations that why continue to struggle? Why continue on? Low energy levels. Like, are they not able to engage in physical therapy as they're getting better or in any sort of aspect of their treatment? Suicidal ideation is something that's very obvious. When people bring it up, it should be a glaring big, like, hey, we need to get this person to some mental health or at least have some interventions. But also concentration, like they're looking like they've changed, speech difficulty that's progressive, difficulty with emotions with their family members. So some of the things are not going to be on screeners, but if you can see things where they're having conflicts with their family members or conflicts with their caretakers, that's a good indicator that, hey, maybe it's time to get some help. But the tried and true are definitely PHQ-9, GAD-7. There's some for sleep as well. And then I would advocate using like a PCL, which is inventory for post-traumatic stress disorder, to see if they're suffering from that as well. Because many times that can be confused as people developing worsening generalized anxiety, where it's really just the hospital itself is causing to feel traumatized or more anxious and have difficulty sleeping and other issues.
Okay, so it sounds like we should pay attention not to just to the words they're saying, but to body language and a lot of other interactions going on at the same time. We sort of alluded to this, but how should a hospitalist handle a request for physician-assisted suicide, or if somebody expresses interest in it? What's the initial approach to how to handle that?
You ask a very two-part complex question, one of which is definitely like a fodder for an entire episode in and of itself, like the moral and ethical questions behind physician-assisted suicide. But the second part is suicide. It's not just a linear thing. Many times we try to break it down. Like human behavior is incredibly complex and almost nearly impossible to predict. You can predict it on gross levels with large populations better, but on the individual, it's super complex. And the approach towards suicide itself is incredibly complex. The first thing I would say is engage with mental health. It's somebody who deals with it a lot. But as a human being taking care of another human being, trying to help them, taking 5-10 minutes to explore why they say those things. Not all suicidal ideation is created equally. Some people feel hopeless because you imagine going through a major journey and it feels like insurmountable, like you can't take it on. Or just figuring out, do they feel isolated? Is their family leaving them alone? Is there some aspect, do they feel isolated from their family being stuck in the hospital? But there's usually qualities of a human being that's suffering, that's usually a common thing, that creates some of these feelings. And it's important to explore it. It's not just cookie cutter, they're suicidal, so they need to go to a psych ward. There's complexity to it. And I would say that the vast majority of people have at least some level of, if not suicidal ideation, like you talked about before, the morbid ideation, like why do I continue to struggle? What's the purpose of going on if I have these dysfunctions or these problems? Especially with Tina, she may have a lot of residual issues that have changed her life permanently. And it's just important to explore it. And the one thing I can say is usually mental health has a little bit more time to do that exploration. We're given a little bit more latitude with our patients.
Well, I really appreciate you're talking a little bit about the physician-assisted suicide. I live in a state where it recently was legalized, and so I kind of thought that might be on the minds of some practitioners. But let's move beyond Tina's case. I want to get your thoughts generally on when it is appropriate to intervene. I came across a study conducted in 2008 that revealed several barriers to primary care clinicians intervening in individuals with possible depression and anxiety. Those barriers are difficulty making the diagnosis, lack of expertise, competing priorities in practice, patient resistance, a fragmented behavioral health care system, and insurance coverage. I can imagine hospitalists deal with these barriers regularly. They are rightly focused on the patient's physical disorder as well as the disorders of other patients in their care. It's easy to push behavioral health matters to the back burner. And in fact, it's often with the assistance of the nursing team that these issues are brought to the forefront. Even when they decide to intervene, hospitalists might wonder whether it's the right move. Starting treatment for depression and anxiety carries certain risks. Dr. Hunzeker, can you identify those risks and how hospitalists should think about them in the inpatient setting? Can you make us feel better about intervening?
Everything that you just highlighted is incredibly important. But I will also say, especially a lot of the limitations, like if I start something, where will I hand this patient off to? If I open up this issue, am I going to be able to resolve it? But the things I would argue is that they exist. If there is depression involved, especially in these patients, like post-stroke patients, they're incredibly common. If it's as high as 40%, that's half of the patients that are coming through are going to be suffering from it and knowing that it's going to get in the way. The second part is a lot of the interventions that you're going to be dealing with are primarily for primary care. I think it's something as high as 80% of mental health patients receive their treatment from primary care. The vast majority treat more mental health than I do. So it's like I may treat more severe and complex illness, but the vast majority of depression and anxiety will be treated by generalists. And that's just because of the need. There's such need and not many assets. Some comforting thoughts are antidepressants are incredibly common. 1 in 10 Americans will be on them at some point in their life. This is a very high number. They're very well tolerated. Like I said before, antidepressants are not curative. We do not cure depression. It's palliative. We are decreasing a patient's suffering so that they can function better in their healing and in their rehab and in other aspects of their life. And so it's very well tolerated, very good return on your investment for antidepressants. So if nothing else, if you can talk to someone and get them at least referred to different things. In most counties, even rural counties like we work in, Dr. Lucarelli, there are resources that are available, if nothing more than state-funded resources that have like open access to care. But there are resources and there are ways to do it. And many of the things it's familiarity. Like if you want to talk to me about blood pressure, I'm sure I don't know much, right? But there are things that you can do. Starting antidepressants, I think that everybody can do. Something like a Zoloft or a Prozac or a Lexapro. It's very safe. It's very well tolerated. There's very low side effects. And then getting them referred to other sorts of cares. And most hospitals now also either have integrated mental health as some part of it or consult liaison, which is available to help support, if not through education, then seeing the patient themselves. So I think that it's much of it's a comfort issue. Like with all physicians, as we become more specialized, we become more narrow. We feel uncomfortable with approaching different illnesses that we are not typically used to. But I also think that's my call out for multidisciplinary treatment teams, where you get as many different kind of specialties together that can work in a collaborative way to take care of patients the best way possible. And many of the time, that collaboration is just us sitting in the same areas, so someone can ask them a question about a case and give them education on it.
I've often, with patients, if I wasn't sure how they would take my bringing up the issue of depression, I've often said, how are your spirits holding up? And use that as kind of a segue to kind of let them talk a little bit more about their illness and what they're feeling. One of the most tricky areas is with regards to somatic symptoms of anxiety and depression and how they relate to the underlying medical illness. What advice do you have for hospitalists that struggle with this, like how to separate out and deal with the physical symptoms that patients talk about rather than actually identifying it as a mental illness?
Absolutely. When we talk about diagnosis, we always have to be careful. A lot of people get scared off by a diagnosis. And so approaching someone on a human level like you advocate, how are your spirits? How are you? Knowing that nobody's happy when they're in a hospital. Very few people are happy to be sick and in a hospital. And those are probably the people you need me to see. So most people are upset. Now, the question if they're diagnostic or depression, it's important that you get somebody in there to have those conversations with them. And so the next part is kind of what do you do to try to approach someone who doesn't really want to talk about mental health? Is that what you were asking about?
Yes, right. If the symptoms they're describing are physical in nature, and you suspect they may be more related to the underlying anxiety or depression.
So the two things I would talk about, one are cultural phenomenon. Different people feel different ways about talking about mental health. So many people may describe them or feel more comfortable describing those issues in a physical manner. So everybody has a different level of comfort. So some people will talk about it and use different words for it. Like some people will call it dizziness or pain, and they'll point to their arm. But as you talk to it in context, it seems like it's much more mental health, like feeling depressed or fatigued. Some people are willing to talk about it in different ways, metaphors like that, like weakness. And I think it's incredibly important to, understand how common, like we talk about depression like it's something I can test with an MRI. So a lot of studies where it talks about like how many people go through the hospital and develop depression, they're going to be wildly inaccurate because they're asking people how they feel. And that's one thing we touched on before. One part is your review of systems. What did the patient tell me? One part is what you see with your eyes as a physician, the actual physical exam, which I would contend is more important. So when you talk about physical symptoms, just be aware the brain is attached to the rest of the body. So when things produce themselves physically, many times it's a sign of severe stress and anxiety. We delineate out depression and anxiety as different things. Many times I treat them as the same. They're the flip side of the same coin. It's part of that sympathetic arousal system that's too overactivated, causing a fatigue syndrome or an overuse syndrome that manifests itself in depression. But I would say, yes, somatic symptoms are great. They're assistance to us. Sometimes, different physicians can become fatigued by, this is, fabricated. But really what it is a sign of is that this person's at extreme stress levels, and there needs to be some sort of intervention done, which I would advocate is a great physical sign that it's time to get mental health involved. So it's a good thing. I would also say that it's incredibly fatiguing. It's easier to be the psychiatrist who is called in after the medical workup. It can be very fatiguing and frustrating for a hospitalist to have to work up all of these, it seems like, dead ends. It's like, oh, now they can't walk, and oh, now they're having seizures that they can talk through, and all these different things. And that can be fatiguing and very frustrating. I'm brought in routinely on cases like that. And so I can commiserate with that because by the time I'm brought in, usually all the medical workups have been exhausted. And it's a little touchy because I'm the one who has to come in and say, now we don't think it's physical, it's mental. And maybe the patient isn't even consciously aware of how much stress they're under. But it can be very fatiguing for a hospitalist to have to deal with that.
I think what you said is of key importance. These physical symptoms are just a person's distress. It's sort of telling you how much distress they're under, and we should focus on that rather than on getting frustrated that they're quote unquote exaggerating symptoms. So I think that's a good thing to keep in mind. Chronic pain and depression are often linked. What do hospitalists need to be aware of with regards to treating chronic pain-associated depression?
I would say the exact same thing, which is try not to get too stuck into boundaries of things you treat and don't treat. Patients come at us from all sorts of complexity, and complexity just really means we're treating the whole patient. A patient with chronic pain needs to have chronic pain addressed, and there's no great answer to it, but it is saying a complexity level, and that it's going to be more complex, and there's going to be a finite gain that we intervene on it, but it can't just be ignored, because if we don't address it, it'll be more like 2014 when we have troubles in it. But I would also say that anybody who's suffering from chronic pain likely needs to have mental health involved at some level, even cursory or through assessments, because it's probably also much like a sign is watching those somatic symptoms. A good sign is the interpretation of pain. People under mental health issues and high stress, their pain is worse. And everybody who's ever had any pain is aware of that. Like if you're distressed and stressed out, your pain appears of higher magnitude and a greater obstacle in your daily functioning. So sometimes we can help with that by improving mood, improving sleep, get them in front of pain specialists. But it's just what it says to the internist is you are dealing with a complex problem and you need to ask for help.
Okay, and it may be similar for substance abuse. Do you have any special considerations to add for folks who have depression, anxiety, and associated substance use disorders?
I believe them all to be of similar issues, which would be classified as fatiguing for the hospitalist, because there's a lot of character overlays with a lot of these patients, characterological overlays, issues with distress that can be fatiguing when an internist is usually a goal-oriented person who's fixing problems. And so some of these problems, they're not fixable, or at least not in a hospital setting quickly. And so that's why I would also say on terms for the physician as well, call in for help. Because if nothing else, it can be fatiguing trying to take on one of these complex cases that feels like it's dragging you down and running you down all these procedures that aren't needed, or running you into different things that is fatiguing, especially like substance abusers many commonly times will leave the hospital, AMA, halfway through their treatment, come back, leave again, or they won't abide by your treatment programs. I think about some of the people with chronic infections that won't abide by their treatment programs or leave early. And so it's just ask for mental health care help. And if your hospital doesn't have it, it's one of those things where it's time to figure out a way where you can at least become more collaborative with outside the hospital resources, anything to get better ideas. But if you try to go it alone, I think you'll be very fatigued and overwhelmed by a lot of these patients.
Let's close out our episode by summarizing some key takeaways. Depression and anxiety are often associated with medical illness and can impact outcomes, readmission rates, and length of stay. Treatment and diagnosis of depression and anxiety are often complicated by substance abuse and chronic pain. And depression and anxiety often go unaddressed for a variety of reasons. Identifying barriers to care is important, and providers should educate themselves on both pharmacologic and non-pharmacologic options for treatment. Consider anticipatory guidance if risk of developing depression is deemed high.
The opinions expressed are those of the reviewers, authors, and commentators and do not necessarily represent the views of Oakstone Publishing. Please review the complete prescribing information of specific drugs or combinations of drugs, including indications, contraindications, warnings, and adverse effects before administering pharmacologic therapy. Thanks for listening to CME Essentials in Hospital Medicine. To learn more, visit oakstone.com.